Great.
Okay, lovely. Can you see my presentation clearly? Yeah,
Yes, yeah, perfect.
lovely. Just bear with me there. Okay, so hi everyone, I'm Ursula and thank you to Dr. Anne-Marie Bennett for the introduction and to the organising committee of the conference for asking me to provide a very short presentation on the work we've done around clinical reasoning here in UCC. I certainly don't claim to be an expert on the topic, but I suppose just a bit of background. My interest in it started back in early 2020 when our external examiner posed the question to us as to how we teach and assess clinical reasoning here on the programme in UCC. And I'm not sure I'm sure we were all confident that we were doing it, but we didn't know how to capture this or to report back. I suppose in the absence of, what is the theoretical knowledge behind it. So I suppose it sent me down a rabbit hole that I'm still down and led to very interesting findings and ultimately a greater confidence in my role as practice tutor. So just to acknowledge my wonderful practice education team here in UCC. Together we've developed and delivered the training that I'll talk about around clinical reasoning, and we're led by Dr. Joe McVeigh. So just to thank him as well. The objectives of today really is just to reflect on your own practice at the moment and your own knowledge of clinical reasoning, explore the theory of clinical reasoning very briefly and share the work that we've done here. So hopefully you'll be able to take away a couple of practical tips around clinical reasoning. I think it's worth asking yourself what you know about clinical reasoning. It's a term that's used a lot in physiotherapy, for sure, in our grading documentation. So we see it dotted throughout the documentation, and in conversation with educators, we hear things like their clinical reasoning, it doesn't seem to be great, or they're struggling with the analysis side of it. They need a lot of help to come up with a problem list. And I suppose, having worked for a decade as a clinical educator, when I had these types of students, I'm not sure exactly.
So sorry, if I can come in there. I don't know if you want to share your full screen if you want, but if you want to, you can click slideshow either. Because
Sorry.
we can just see the other elements on the screen, but just whatever suits you.
Sorry.
No,
I
no,
can.
it's fine. It's
I
fine.
have loads of screens going on here.
Oh yeah, no, whatever you're most comfortable sharing is absolutely fine. Like we can still see the slides, so not to worry.
Can you see that? No.
We're seeing kind of a bigger version of your slide. I think that's
Resume slide. Don't know why it's not.
Honestly, I think that's fine. We can see a bigger version of your slide there, so that's perfect, really. Yeah.
Sorry, I don't know.
Really nice talk.
I'm hitting slideshow, but resume slideshow. I did get a new laptop last week. Anyway, so I think it's worth, I suppose for me as an educator, I would have, as with a student who may have been struggling, I probably would have just thought that, give them a little bit more time, let them, see more patients, and it probably will just come naturally. But I suppose having done a lot of reading on the topic, there's definitely things we can do to support this process better than that. So here's the definition of clinical reasoning, which you can see is long and complex, and it looks at that interaction with the patient and environment, collecting the data and weighing benefits, risks of actions, taking into account patient preference to determine a management plan for that patient. So it's quite long and complex, but I suppose that's what clinical reasoning is. It is very complex, and I suppose what's important to note is it's not the clinical decision that's made at the end, but it's more the process that leads a student to that clinical decision. So what have we done to date? So here in UCC back in 2020, we looked at the literature and we attempted to map our curriculum to the theory behind clinical reasoning, and we presented a framework back to our external examiner then in March of 2021. From that and through my kind of participation in a postgraduate cert in teaching and learning, we developed a clinical reasoning training pack. And we've delivered this from March to June, and we're currently gathering some data on that, but we did it both in-house and across a number of training sites. So I suppose within that training, what we looked at was the theory, the models, factors influencing clinical reasoning, which I think is really interesting, and we shared some useful resources. And we looked at the reasons for error in clinical decision making. So for the purpose of today, because it is really only a whistle-stop tour, we're going to look at the theory and the factors influencing, and I'll share some of our support skills, but I'm happy to, you know, discuss this in further detail with anyone who's interested later. So I suppose I've just pulled out some of the interesting theory that I think is really useful to note. So we do know that health profession students need support to gain the ability to make autonomous decisions in an ambiguous and complex context, and they rely on others to see the whole situation. I think it's really important to take 2 points away from this. One is that we must manage our expectations of students on placement. They won't think the same as you, and they won't think at the same speed as you. So it's important that we manage that and that we understand that actually theoretically we're basing a lot of what we know on pattern recognition and experience that our students are lacking at this point in maybe their first placement. So it's important to manage our expectations. And the other thing to note is that by the time we get our students past our first placement, we need them to deem them competent. So there is a massive onus on the HEIs to consider clinical reasoning across their curriculum, so that we get our novice students in September, and that we work with our students until they go out in their first placement, using activities and you know that are linked with clinical reasoning. The dual process theory is interesting, and it's interesting to understand how we think as clinicians. So we operate as an experienced clinician through a system 1 and a system 2, which is for the most part automatic and effortless. So we go into work, we're not too exhausted, we've seen things before, we understand the patterns and the usual presentation of certain impairments. And then there will be times where we're challenged and we'll have to explore and ask for help or look something up. And I suppose that's how we can work without being totally exhausted, and its efficiency. It helps us to be efficient and see more patients. But what our students will be doing is they'll be operating almost completely initially in a system 2, until they gain enough experience and exposure that there's a little bit of pattern recognition comes in. But we must accept that our students will require that time outside of patient contact to reflect and to think about what's just happened and to research and look things up. So it is a very different way of learning, and it's why a lot of our students will report exhaustion while on placement. This is interesting, and I suppose what's really interesting is that actually it came up a lot during the previous talks today. These are the factors which influence clinical reasoning. So if there's an issue with any one of these, you might find that your student may not be performing so well in the areas of clinical reasoning. It's really useful to understand these, so that when you do have a student who's struggling, you can go back and try and pick out what might be the issue. Critical thinking skills is that ability to be open-minded and to think about what they're doing. Metacognition skills is really interesting, because I think it really speaks to what Dr. Christy Noble spoke of earlier, you know, in putting the learner in the center of their feedback. Metacognition is that students' ability to be self-aware and self-critical, and I think getting students to be the center of their feedback is a key skill that we've used here in UCC to develop these skills. Data collection and procedure will be kind of profession specific. A knowledge organisation isn't about how much a student knows or how academic they may be, but more about linking that theory to practice and their ability to do that. And therapeutic alliance, again, Anne-Marie Scanlon spoke of the empathy. This really speaks to this. So therapeutic alliance is our students' ability to empathise with patients and create that collaborative relationship with the patients that they're seeing. And that's really important. It can really negatively impact a student's ability to reason. I'm just looking at one of these factors today, but as part of our training program, we looked at each of the 5 factors in great detail. What we look at is what is critical thinking, and then resources that we have in order to develop these critical thinking skills. Anything highlighted in yellow are resources that we've made available to our clinical educators. And I suppose for me as a tutor, I create a 7-week schedule or timetable for our students, and I'll always dot these activities throughout the 7 weeks, so that I know that all of our students are, you know, getting targeted activity to really support an essential component of reasoning. And obviously for students who may be struggling in the area of critical thinking, we'll do more of this and we'll put that into their action plan. Not going to go into too much detail on this, but this is just another resource we've developed here to guide educators on how to manage a novice or a beginner student or a more competent student in clinical reasoning. This strategy has been really useful in grading, so we've been able to refer back to it and think actually what level are they at, and that in some way ties into the CAF form that we use as a grading tool. Lateral thinking activity is another useful, don't really have time to go into it too much, but you know, just I think students and all of us will veer towards the lesser cognitive load, and we'll go to kind of, I suppose, a memory bias really, and something maybe a patient we've dealt with before where a successful outcome was achieved. So in this case, you know, a patient admitted with a fall, if a student has previously had a patient who's had a fall and it was linked to a balance deficit, they'll automatically try and pin it on balance. So it's just trying to probe your student through questioning and through this activity to consider, okay, well, it could be that, but what else could it be? Is there anything else in their history that could have caused this fall? Really useful one to kind of encourage that open-minded critical thinking approach. Across the literature, it does say that variability in terminology and methods of teaching can confuse students as they attempt. So I think from a curriculum point of view, it's really important that we use the same documentation in the university as we do out on placement. So immediately in semester one of our students, we'll introduce them to our clinical reasoning forms, which are, I suppose, moved on slightly from that kind of hypothetical deductive model of reasoning to that biopsychosocial framework, you know, as suggested by the World Health Organization through the ICF model. So these documents are just such a useful resource, and really, I suppose, they speak to all of those factors that we spoke to earlier on, you know, that linking of theory to practice, really important. This was an absolute whistle-stop tour, but I think it is worth everyone who's involved in practice education across a number of different professions to consider, you know, how the curriculum links to your placement. Really very useful activity. This is a brilliant book. I would recommend that you would put it on your reading list if you are working with students. It really helped me to understand the reasoning process, and I suppose Claire Whelan earlier said that we're not trained educators. We're, like, I'm a physiotherapist primarily, and I suppose engaging in reading and engaging in further, I suppose, education ourselves on the delivery of education and improving those processes has been hugely beneficial to me and ultimately to the experience our students get. But this book is excellent. It does go into different professions, and physios mentioned there. I will say though, recently I worked with Ellie and Teresa here in audiology, and we delivered a training program to the educators around clinical reasoning. I don't know anything about audiology, and we were very easily able to use the theory to support that workshop. So you know, it's just a brilliant book for all health professions here today. So I do have a reference list at the bottom, and there are my details, but if there's any, I don't know if there's time, but if there is any time for questions, I'd be more than happy to take them.
Thanks very much, Ursula. Really super to see all of that work, and yeah, again, like so many, I think, practical takeaways from that, and great to actually, yeah, see that book, even just for people to be thinking of. Really interesting, I suppose, as you say there, really thinking about clinical reasoning as the process leading to the decision, not the decision itself, and the you know, I just think that's a really nice piece to contextualize. In terms of, you mentioned there, like using the same forms in college and in the placement setting, kind of around clinical reasoning. In terms of are there any challenges with that, or kind of what did it take to implement that, or what kind of activities are they most classically used for in college, or how often?
Yeah. So I suppose primarily it's problem-based learning, and we do try. I mean, there's a lot of detail in the book around simulation training, and ultimately across all of the literature, like practice placement is the most effective way to develop these skills. There is no doubt about that. But I suppose what we can do in college is to try and simulate it through problem-based learning, or sometimes through getting in expert patients to come in and at the end of the session we ask our students to fill in that same paperwork in college that they would do out in placement. So fill in a clinical reasoning form, or some of the other reflective tools that we use kind of.
And this is from year one, is it? From year one?
Yeah, from year one.
Yeah, super.
Yeah,
yeah, it's great for, I'm just even thinking, for students to be able, maybe adds weight to it as well when they're using the same documentation in college as they are in placement, and students are really seeing that thread.
And I think what probably wasn't captured on that is that it is really important to educate our students. I think somebody mentioned it earlier, to understand why they're doing it, because the clinical reasoning forms it's a big activity, it's a big chunk of work that we ask the students to do at least once a week. And I think it's really important that they understand why, and that they understand the process of clinical reasoning. So I have a different version of a presentation for the students, but I think it's really important that they understand that they won't think like the educators, and that's okay.
Yeah, and I think that whole ethos is lovely, and I think again, that real inclusive mindset with the students, I think, and enabling them to kind of take ownership, it again really primes them to be in a really good position when they have a really good understanding of how they learn. I think to be able to kind of subvert that and to be better practice educators then when they have students.
Absolutely,
all of these initiatives feed forward, I think, into that enhancement of the workforce. But we're to time there, but thanks very much for that, Ursula.